Now we'll turn to post-surgical imaging and how this affects the uterus in terms of diagnoses, as well as particular problems that may arise in this patient population that you need to be aware of. This patient gave us a history of having had a hysterectomy. We were initially imaging transabdominally. She had a fairly well-filled bladder, and we noticed a solid-looking structure behind the bladder. This is it in transverse with a little bit of a cyst in it. We went on to image transvaginally, and this clearly is the appearance of a perfectly normal cervix with Nabothian cysts. And so this patient had a supracervical hysterectomy. Every now and then you'll find the cervix that's left behind and the patient may not realize it. This patient gave us a history also of a hysterectomy, and here's the initial transvaginal imaging, and the interpretation of the sonographer who came out was that she thought that there was some piece of uterus left behind or that there was some sort of complex solid mass with cystic components. Upon further imaging, it turned out that these were actually the ovaries, the left ovary and the right ovary, and that they had fallen down together near each other in the cul-de-sac and were touching each other here and making it seem as if there was one mass. So they were perfectly normal ovaries, no uterus. Now we'll turn to the patient who's had a cesarean section. As you may know, or depends on where you work and live, but in our country, there's been an amazing rise in the number of cesarean sections over the last 10 to 20 years. And so many patients come to us having had one or more cesarean sections. And the kinds of problems that arise from this for us have made it so that this is one of the specific questions we ask patients before we begin imaging them. If you just ask if the patient's ever had any pelvic surgery, she may not feel that this is pelvic surgery and might not mention it. But knowing that there has been a cesarean section may lead one to image in a variety of different ways and expect certain things. So here's a typical patient who's had a cesarean section. We initially looked transabdominally, and there's a very odd shape and contour to the uterus. So in the sagittal view, head here, feet here, this is the urinary bladder, vagina. You notice the cervix, and it appears relatively elongated, and then if you follow the uterus up to here, it's tethered and pulled right over here. This is the transverse view through the same level, and this is actually where the cesarean section scar is, and it pulls the uterus up, and it's stuck there. And the problem is that if you continue to fill the bladder, it will just push this up further and further. The bladder will never serve as a good sonographic window for the uterus. The other problem is that transvaginal imaging is often limited in these patients. I've taken a sagittal reconstruction of the pelvis from a CT scan in a patient who's had a prior cesarean section and placed next to it a drawing of what it would be like if we tried to do a transvaginal study on this patient. So here's the urinary bladder. This is the fundus of the uterus, and the tethering and scarring is right about at this level. This is the main body of the uterus, and you can see that the cervix is pulled and elongated because the uterus is tethered here. So if you put the probe in the vagina, which would be about here, and you image, you'll get an absolutely wonderful view of the cervix. And it will be so elongated that some people think that's just the uterus. And you may never really be able to image the body of the uterus, which is up here. Here's another patient, and I'm going to show you the ultrasound views and the CT views so that you can appreciate this. Here's transabdominal. This is the bladder. Here's the elongated cervix with the tethering right here. And here's the body of the uterus. In transverse on a CT scan, this is the uterus, and here's that pulled up tethered portion. Oftentimes the ovaries are also pulled up out of the pelvis as well in this situation, also making it difficult to image. This is the sagittal reconstruction, and this scar is so prominent you can actually see the adhesion to the anterior abdominal wall. If I flip this image vertically, essentially you will obtain what we have when we image transvaginally. So here's the patient transvaginally, a lovely view of the cervix. Here's the cervix, and the body and fundus of the uterus are far from the transducer. Here they are here, and oftentimes we just cannot penetrate far enough with a transvaginal probe. So what to do? Well, it's a problem. The scarring can cause significant distortion of the normal position. The cervix is elongated. There's poor visualization of the body of the uterus. And additionally, transabdominal imaging can be very limited, and there's a poor sonographic window. So our recommendation is, if the patient body habitus permits, to actually try a higher frequency curved transabdominal transducer directly over the uterus without using the bladder as a window, and you may actually be able to image the uterus. Every now and then, sonography will fail in some of these patients, and other imaging will be needed. Here's a patient on transvaginal imaging, also a history of a cesarean section, and the person imaging was questioning this region as a myoma. And you can see it here and here. Does this patient have a myoma? This is actually a cesarean section scar simulating a myoma. The scar is right here, and there will be some fibrous tissue, and sometimes you get this sense that there is actually a myoma there, when if you look carefully, this is isoechoic with the normal myometrium. Is there focal endometrial thickening in this patient with a cesarean section history? You can see right here, there's sort of a bump up of the endometrium. And what this represents, this is it in transverse, is the scar with pulling and tethering of the endometrium in towards the scar. These two patients give a history of intermenstrual spotting. This is an important history to obtain from the patient, as well as knowing that both of these patients had prior cesarean sections. In this patient here, you can see a little bit of fluid in the endocervical canal, some complex fluid, and the fluid tracks into the place where the cesarean section scar is. This second patient had an even larger collection of complex fluid in the cesarean section scar, and you can understand why a patient like this might have spotting in between menses. This place is called in the literature by people who have written upon it a niche or reservoir for blood. This patient came to us with a history of heavy menses and also some intermenstrual bleeding. When we did her imaging, we were pretty confident that there was a large myoma centrally, which we thought was submucosal or even intracavitary, and her physician asked that we do a sonohysterogram. Upon installation of the fluid, we outlined the myoma and confirmed its location. In addition, the fluid outlined the little niche or the scar from the cesarean section and filled it. And you can actually see how thin the myometrium is at this point. So you can see these little niches or reservoirs on sonohysterography. Other complications can obtain in such patients. This patient, who had one prior cesarean section, came to us with an early pregnancy and bleeding. These images were interpreted by the physician doing the study with the sonographer as an abortion in progress. Here's the gestational sac low in the uterus. The patient passed the sac and the bleeding stopped. Unfortunately, she returned 1 month later with recurrent bleeding. These are the images we obtained transabdominally at this point. The sac was gone, but there was some echogenic material at the same location. And when we turned on the color Doppler, it was exuberantly vascular, and it had low resistance flow, typical of trophoblast. So what this patient actually had was a pregnancy that had implanted at the cesarean section scar site, an ectopic pregnancy. She had actually passed it, but had retained products of conception at the site of the cesarean section scar.